So welcome to the webinar, Everything You Forgot About Removable Partial Dentures. The lecture will be presented by Wendy A. Clark, DDS, MS, FACP, and we will begin shortly. And now I get to introduce Dr. Wendy Clark, DDS, MS. Dr. Wendy Clark completed her undergraduate training at the University of Georgia and earned her doctoral degree from Marquette University School of Dentistry. She then earned her master's degree in clinical dentistry and a certificate in postgraduate prosthodontics from the University of Alabama at Birmingham School of Dentistry. Dr. Clark practiced prosthodontics for 7 years with Team Atlanta and lectured nationally on a variety of topics, ranging from smoking cessation to dental implants. She was named a leader in continuing education by Dentistry Today in 2017. And currently, Dr. Clark is full-time faculty at UNC Chapel Hill Department of Prosthodontics. And with that, I get to say, take it away, Dr. Clark.
Thank you, as always, for the best introduction, Jessica. Today, I'm excited to share a topic that is not always the most popular, so I'm super excited to see so many faces here today, and that is removable partial dentures. In a time with implants and so many different zirconia and fixed options, a lot of times we don't think of RPDs as the cool kids on the block, but they certainly do still have a place in our practice. And particularly patients who can't have implants for financial reasons or medical reasons, or patients that are too young to have implants and they need an interim prosthesis, or the little corner on the top right is my most common patient population. I have a lot of patients who are kind of in that almost terminal dentition where we know that the teeth are going to be gone someday. They will transition to an implant or a fixed full arch prosthesis. But in the meantime, they'd like to hold on to what teeth they have. So we call those kind of transitional patients with transitional partials that have a terminal dentition that are certainly someday going to lose the rest of their teeth. The majority of this presentation will be about cast frame removable partial dentures. These kind of encompass a lot of the more complex topics. And so if you can understand cast frame partials, it helps you with your non-metal partials as you move into that portion of your treatment planning. So before we can talk about partials, we need to speak the same language. And the language of removable partial dentures is the Kennedy classification system. The classification of your patient is going to be determined by the location of the edentulous area, not the number of the edentulous areas. So, for example, a Kennedy Class 1 patient has 2 distal extension or tissue-borne edentulous spaces, so no teeth on either side. A Kennedy Class 2 will have a single tissue-borne space, a single edentulous space without a tooth in the back. And a Class 3 is going to have a single, or is going to have a tooth-bound space. They may or may not be a modification on the other side, but it's a posterior tooth-borne space, meaning there's a tooth on either side of the edentulous span. Kennedy Class 4 is going to be an edentulous span that crosses the midline that's also tooth-borne. And this is just writing that in a different way for those of you that are more word-oriented rather than photo-oriented, going through the different Kennedy classifications. To modify that and kind of further define these, Applegate made some rules to try to make it easier. So I hope this helps and not make it harder. But it's always determined by the most posterior space. So when you're looking at the edentulous spaces your patient has, whichever one is furthest back in the arch is going to determine what the patient's Kennedy classification is. And you don't classify your patient until after all the non-restorable teeth are extracted. So not before extractions. If you know you're going to take out a few teeth, you wait and classify them after, or you can say what they will be once the teeth are out. You can consider second and third molars in classification if they're going to be replaced. If a patient has more than one edentulous space, anything aside from the most posterior space will be a modification space. And so we call them mods. And last but not least, a Kennedy Class 4 cannot have a modification space by design, since anything posterior to it that's edentulous would turn it into a Class 3. So we'll show a few cases as we go throughout. This one, for example, would be a Kennedy Class 2, because we have the distal extension space on this side. Modification 1. So we call this a Class 2, Mod 1. And just showing on the side, this is a tooth-borne space, meaning that where the edentulous span is, there's a tooth on either side of it. And this is a tissue-borne space, sometimes called a free end, sometimes called a distal extension. But those are kind of the two types of areas you deal with RPDs. And when we look at the types of RPDs we can have, regardless of the Kennedy classification, there's really two different types. Those that are designed not to move, which are going to be tooth-borne. When they clip onto all four teeth, they're going to be very rigid. And so these, when the patient's functioning, the teeth keep them from moving up and down on the tissue. Distal extension partial dentures, like a Kennedy class 1 or 2, however, are actually designed to move. So if you have a patient that had a tooth, let's say they were a Kennedy class 3 and then they lost their distal tooth, then it becomes a Kennedy class 2, and now that partial is going to move. And it's sometimes hard to communicate to patients that when it moves when they're functioning, unfortunately, that's the way it's going to be when you don't have that tooth support any further in the back. So we expect Kennedy class 1 and Kennedy class 2 partials to move some on function because they're borne by the tissue, which is compressible. So we're talking a lot about cast frame partial dentures. Those are still considered the gold standard for removable tooth replacement options, and they can be very predictable. The frameworks tend to last for several years. However, we have now some metal-free options, and we'll talk about those a little bit later on. So, and today we don't have to cast frameworks the way we did back when I was in dental school. You can now design your framework digitally and have that made with either 3D printing or milling technologies. And they can be milled out of the exact same material that we're casting them out of, which is a cobalt chrome alloy or a titanium alloy. By and large, the cobalt chromium is the most common alloy we see, or the common framework material we see with removable partial dentures even today. Titanium doesn't quite polish the same, and it has a little bit different physical properties, but it certainly does work well, especially if your patient has a lot of titanium implants or abutments in their mouth. You might not want to add dissimilar metals in there. So if you have a patient that has a lot of implant crowns, a lot of titanium abutments, maybe a bar overdenture or something like that, certainly a titanium framework could help prevent some galvanic shock or some other issues down the road. When we're talking about digitally fabricated removable partial dentures, this is an example of what a milled framework might look like. So you have a puck of metal, and it can be either cobalt chrome, it can be titanium, or any other alloy that your lab might have in stock. And then it gets milled out the same way you would mill out a bridge or a CEREC crown or anything else in that process. We can also additively manufacture frameworks, which is 3D printing. There's a metal printer that uses either SLS, which is selective laser sintering, or SLM for selective laser melting. And basically, there's a bed of powder metal, and the laser hits it the same way it works with a 3D printer, and you end up with a framework made out of that material. You can SLM with the same types of alloys, so cobalt, chrome, and titanium can be 3D printed. And this is a picture from a journal article kind of walking through that workflow. And with this, there've been plenty of studies on patient satisfaction with different metal restorations as well as fit. And what they have found is, with all these different articles, if you did a lit review, that you'd find that the selective laser melting or the 3D printed frameworks are very, very comparable to the cast frameworks. So we're not seeing a difference or one being better than the other. We're seeing an equivalence. So when we're making these cast frame removable partial dentures, they tend to take quite a lot of appointments, which I think can be a deterrent for these prosthetics sometimes. I usually tell my patients I expect a minimum of 4 appointments as we go through the process once we get to impressions, but usually an average of 5 or even 6 or more, depending on the complexity of the framework. At that first appointment, we're going to start doing our diagnostics and get some impressions and records, present the treatment plan. And then once we've kind of designed our partial, then we might do tooth modifications or other mouth preparations, get our final impressions, go to framework try-in, tooth try-in, partial denture insertion, and then any post-operative visits. For any removable prosthesis, especially a tissue-borne prosthesis, I tell my patients an average of 2 postoperative appointments can be expected. Some people don't need any, some people need many, many more. For any sort of prosthetic planning, I like to think of the different phases in acquisition, design, and fabrication. Acquisition is going to be acquisition of data. So we're collecting photos, x-rays, interocclusal records, scans, all the data about our patient that we need to really treat them in the best way we possibly can. Once we get all that, we design our treatment plan and start going through our prosthetic restorative sequence chair side. And then after that, we send to our lab to get our prostheses fabricated. So in that data acquisition phase for partial dentures, it's kind of a combination between what you would do for fixed work and what you would do for complete denture work. And so I think this is one of the more challenging prosthetics because you have to have a really great knowledge both of the fixed side as well as the removable side. So much like any fixed implant prosthetic, we want to make sure that we know where the patient's teeth meet up, evaluate their current plane of occlusion, if there's any hypereruption, make sure that we have space for all the different materials, and really evaluate everything that we need to have a really successful prosthesis. Oftentimes, we'll need pre-prosthetic surgery or periodontal work on those teeth or restorative work before we can restore them with a partial denture. And so it's really, really critical before you tell your patient you can make a partial denture or what material you're going to use or how many appointments it's going to take, that you look at your patient's diagnostic data. And that could be a conventional workflow or a digital workflow, and we'll walk through both. But you really do need to see your patient's articulated records before you go through and finalize the plan. And those records we need are going to be the same, no matter whether it's implant, fixed, removable, complete. Is going to be a vertical record, which is measuring vertical dimension of occlusion, a horizontal record, which is where the mandible relates to the maxilla, and an orientation record. The vertical record, again, is VDR, VDO, making sure that you know where your patient's bite's supposed to be in a vertical space. Horizontal record is usually either an MIP or eccentric relation, and then an orientation record, which conventionally would be a Facebook, and now may be a photograph for a digital Facebook transfer. The 3 different types of horizontal records you can take for rehabilitations are going to be maximum intercuspation, or MIP, MICP, centric relation, which is CR, or a neuromuscular position. Typically in the dental schools in America, we'll teach the MIP and the CR, and that's pretty common from what I've seen in the literature for education around the world. So we'll live in these 2 areas. Neuromuscular is more of an advanced treatment that would require a more advanced training. So how you decide CR versus MI? If when your patient does not have their partial denture in, if their occlusion is stable, that's when we would consider a maximum intercuspation record. So if you look at the casts on the bottom, this patient has all their posterior teeth, just missing a few anterior teeth. This is a great case for a restoration made in maximum intercuspation. Alternatively, if you don't have stable occlusion when the partial's out, at that point, we would want to consider doing a centric relation record. So the way I teach my students is if you don't have a stable tripod of teeth, then you're going to be looking at a centric relation position. And what I mean by that is when you have your patient bite down, when they chomp down, if you have a contact in the posterior on each side and a contact in the anterior, now you have a 3-legged table, and it becomes a very predictable position to restore. If you're missing any of those 3 legs of the table, your patient's bite becomes very unpredictable, and centric relation is going to give you a nice home for that. So as I mentioned, you do need to get these records. They don't have to be the conventional records you took in dental school, but if you'd like to, you can. So this is me being a guinea pig, and you'll see me a lot throughout my presentations, but you can do a Facebook transfer, get stone casts. You need to mount a cast like this where you're restoring an MICP with a record base. And this is showing that where you don't know if the patient's bite looks like this one on the left, where everything is kind of flat, or maybe they have a cant to their mandible and it looks more like the position in the middle, or it could be anywhere in between. So really, when you don't have that tripod, like in this case, you do need to make a record base with wax rims if you're doing conventional records. You can sometimes make this a little bit more streamlined with digital records. And in these cases, I would do an intraoral scan, a full face photo that shows the eyes and the ears, and then we can do a digital face bow from there and get an interocclusal record in centric relation. There's been lots of data showing how you can merge these photographs into the software. But I think one of the key points of this is when you take your interocclusal record, so when you're mounting your casts, whether conventional or digital, they need to be scanned in the position you plan to restore your patient. So in other words, if you're going to do an MICP partial and you want your patient just to bite together in their normal MI position, then you have the patient bite down in MI when you do your physical record or your scan. If you want to restore your patient in centric relation, your scan record needs to be made in the centric relation position. And this is just showing a quick video. Again, I'll be your guinea pig. We're using a Lucia jig to position my arches into centric relation. And so now we're going to scan my interocclusal record in CR. So it'll be an open bite position. And the scan will relate those arches in that position. So you see this is an open bite scan, but I'm positioned in CR. So now when we go into the design software, if we need to open or close the vertical, we can slightly, but we have the jaws oriented already in the correct horizontal record. This is another example of trying to get a CR scan. And so a lot of times these very collapsed patients, you'll need to open them up if they don't have a stable home like this one. So you can do bimanual manipulation. You can utilize a Lucia jig. You can utilize a leaf gauge, whatever you would normally do to take your centric relation record. Utilize that same technique, but scan your patient and it'll maintain that position for you there. All right. So we had talked about having the combination of the fixed and the removable side. You need to, when you're treating a partially edentulous patient with a partial denture, understand what the condition of those abutment teeth are. And so in this case, we want to know the periodontal status, the endodontic status, if we're utilizing any implants for support, what the prognosis of those are, and how much space do we have for prosthetics? Can we do a survey crown on a tooth, or is there not enough ferrule? And so you have to kind of think about each tooth that's going to be supporting the partial in addition to the condition of the ridge that will be supporting the partial. This is a textbook that came up from Sam Nesbitt. This is actually what I used in dental school 20 years ago. They've been updating to different editions, and I now get to work with Dr. Nesbitt at UNC, which is really cool. So at this point, we are going to get our records, have them mounted, whether digital or conventional. We've analyzed all the teeth, gotten necessary radiographs, determined the prognosis of any teeth that are going to be supporting our partial denture. Now we can get down to the nitty-gritty and start surveying and designing our partial denture framework. So this is everybody's favorite procedure, I'm sure. A lot of times this step is done in partnership with a dental laboratory. In case you don't have your surveyor still from dental school, that's okay. If you do, that's amazing. And every time I give this presentation, I'm always surprised at how many dentists and clinicians still are surveying and designing. It warms my heart. But this is just going to be a quick refresher of what the survey process is. And so if you're delegating this to your laboratory, this is what they'll be doing from a physical side. This is your survey table in case, again, you have some flashbacks from back in the war stories in the sim lab. And we have our survey table with our surveyor, and we're going to put the cast on this table right here. And then we can tilt that to try to find the best, what we call path of insertion. So what orientation will that partial framework come in and out of the patient's mouth? We want to keep it pretty parallel so that the patient doesn't have to do gymnastics when they're trying to take that partial in and out. Preparing guide planes, we'll go over what those are. We want to make sure those are as parallel as possible and try to find a good path of insertion, not only from the tooth side, but also the tissue side. What actually holds the denture in place, the partial denture in place, are the retentive undercuts that the clasp arms engage. So we utilize these little gauges to measure the depth of the undercut to see what teeth are in the ideal position to snap that partial in. So you hear that click when you put it into place. And this tool here is called an undercut gauge, and it measures the depth of the undercut. So this piece coming out horizontally is either 0.01 inches, 0.02 inches, or 0.03 inches. And those are going to be equivalent to a 0.25, a 0.5, and a 0.75 millimeter undercut, depending on which textbook you read. And so here you'll determine where the undercut is. If there isn't an undercut on the tooth, you can actually prepare one yourself and make either a little dimple or build up with composite to create a surface that clasp arm can click onto. And so this is just kind of reviewing. Typically for a cast clasp, we'll use a 0.01 inch undercut on anterior teeth and the premolars. For a second or first molar, we'll usually use a 0.02 inch undercut to engage our clasp. And then in the middle for a Rottweiler, we might want a 0.015. And we'll talk a little bit more about those clasps as we move forward. The tripod is what the lab will do so that if they take the cast off of their survey table, they can put it back on later. And then after that, we're going to mark what's called the height of contour. And so this will become your survey line, and it's the fattest part of the tooth. I say if you have a beach ball, it's the part around the beach ball is going to be the height of contour that your survey line would mark. And so this is a carbon marker, like a graphite pencil, that will mark along the tallest part of the tooth. Once you've found your undercut, you found your path of insertion, and you found your survey line, now you know what teeth are shaped in which direction, and you can start to finally do the fun part and design your partial denture. If you're anything like me, you drew these on your cast, drew them on a piece of paper with your red and blue pencils. Back in art class is what I like to tell my students. But now we actually do have digital options. So most dental laboratories are utilizing either 3Shape or Exocad or the Dentsply Sirona software, where they can scan your cast or take your scan and actually virtually survey and design that partial denture. You can do this too if you want to. There's a free software online, and the website's linked below, that you can actually type in your patient's information or pull in their STL from your scanner and actually do a digital survey and design. So this one's free. The lab ones are usually a little bit more costly, but there now are lots of ways that you can not only design, but also survey your digital casts. But to go back to the analog way and refresh, we're going to draw our rest seats that are actually going to provide the support for the partial denture, the guide plates, which are going to help find that path of insertion, the clasp assembly, which provides the retention, and then the major and minor connectors that hold everything together. So quick review, whenever I talk about dentures, the removable side of partial dentures, we need to look at three important things: support, stability, and retention. Support resists chewing forces or forces against the occlusal plane towards the occlusal plane. Those are given to you by rest seats in this case, because the rest seat stops the partial from seating further. Stability is going to be provided by those major and minor connectors that keeps it from shimmying from side to side. And then the clasp assembly, the clasp arm, right here, you'll see the retentive arm. That's what provides the retention, which is the pulling away force. So when a patient feels like their partial denture's not tight enough, that's a retention issue, and we can tighten the clasps. If they feel like it's moving side to side when they chew, that's going to be a stability issue, which can be corrected by better adapting to the soft tissue and to the guide planes. And then last but not least, if it's moving up and down, then that's a rest seat issue. So that's the support issue. So we'll start with rest seats, which again provide the support for the partial denture. You'll want to put a rest seat on any tooth that is next to the edentulous area. One of the biggest errors I see in the student clinics is going to be not looking at what is on the opposite side of the mouth or on the opposing arch. So when your patient, if you prepare a rest seat that you want the partial denture to sit in and your patient bites together, you have to have 1.5 millimeters of clearance from the opposing dentition. If you don't have 1.5 millimeters of clearance, then that rest seat is very likely to fracture off. So if you make a partial denture framework and then you try it in and the bite is high on a rest seat, if that rest seat's any is not any thicker than 1.5 millimeters, you do need to adjust the opposing dentition. Oops, excuse me. And hopefully you can see my presentation again if you don't mind giving a thumbs up. All right, so minor connectors are, thank you. Minor connectors are going to connect the rest seats and any clasp assemblies and anything else to the major connector. So they're just little connector arms. Next, we'll have proximal plates and guide plates. Those go on the side of the teeth that help keep that partial, give it some stability. We call on a distal extension or a tissue-borne partial, these are called proximal plates, and we usually don't do any preparation to the teeth themselves. When we have a tooth-borne partial, we want to make sure that the partial can slide in between those teeth without creating big food traps. So we will prepare those, and those are called guide planes. So for tissue-borne spans, we don't do any modifications to the tooth. For tooth-borne, we usually will. And again, minor connectors join to the major connector. We'll go through major connectors momentarily, but any of these little sluiceways that go from one component to the other are minor connectors. All right, and we want to make sure we have at least 5 millimeters of space between each minor connector so that the tissue doesn't get impinged and food can pass through easily. All right, major connectors are what goes across the arch and gives the strength and support and stability to the partial itself. And everything on the framework needs to join up to this major connector. So on the maxillary, we have 4 different types of very common major connectors. The first is our favorite at UNC, which is called the anterior posterior strap, or the AP strap. I have found out that my students lovingly call this the toilet bowl because it's shaped like a toilet seat. But I've always learned it as the AP anterior posterior strap. Horseshoe is what is most common, I think, in Alabama, where I did my residency training. It gives the patient the most comfort and least coverage of their palate. And then when I was at Marquette, we did a lot of these palatal straps going across. So lots of different options depending on where you went to school. You may have learned one or the other. A lot of times we'll base these on Kennedy classification. So you can see this full palatal coverage is probably the least common. But in a patient that doesn't have a lot of teeth and you might be going to a conventional complete denture, getting all that coverage might be very helpful. The mandibular is a little easier. You only have 2 options, the lingual bar or the lingual plate, or you might call it the lingual blanket, depending on where you did your training and what book you read. The lingual bar we tend to prefer because it doesn't have as much coverage on the teeth, so you don't have the same risk for plaque retention and caries. The lingual plate or the lingual blanket does provide some periodontal support. So if you don't have a patient that's high caries risk, but they might lose some teeth in the future, providing a lingual plate will make it easier to add any lost teeth back to that partial in the future. The most diagnostic tool that we'll use to choose one versus the other is going to be the amount of space. However, you can only do a lingual bar if you have 7 millimeters of space from the cervical margin of the tooth to the floor of the mouth. So usually we'll measure at the frenum, which is the highest tissue attachment, to the gingival margin here of 24 or 25. And if that's 7 millimeters or more, you're good to go with a bar. If it's less than 7 millimeters, you're stuck over here with a lingual plate. And this is just reiterating that. So you'll measure that from the floor of the mouth to the gingival margin. Okay, so we talked a little bit about abutment teeth, and those are going to be the teeth that retain that removable partial denture. And so those are basically the teeth that have the clasps on them. Another word for clasp assemblies is going to be direct retainers. So sometimes we'll call the abutment tooth the retainer tooth because it's holding that direct retainer. And we're also going to look at the clasp assembly itself. And so the clasp can be made out of, we talked about wrought wire or cast, which would be made out of the titanium or the cobalt chrome. And the flexibility of that retentive arm is determined by a number of things listed here. But the one that I'll focus on right now is going to be the metallurgical characteristics of the alloy. And basically what that means is wrought wire is flexible and cast clasps are brittle. So I have seen both in my own hands as well as my students' hands, a lot of clasps fracture off when you're trying to tighten them. That's mostly common when you have a cast clasp. So when it's made of that cast cobalt chrome or cast titanium. The wrought wire clasps have a lot of flexibility in them. That's what you bend when you make your orthodontic retainers or your temporary partial dentures. Whenever you bend the wire, that's usually going to be a wrought wire. On the back of your retainer tooth or your abutment tooth, you're going to have what's called a reciprocal arm. So you'll see here we have a bracing arm that stays above the height of contour, and then you'll have your retentive arm, which crosses below the height of contour. So the reciprocal arm braces the tooth as that partial snaps on and off. And my friend always demonstrates that by if you push somebody, they're going to fall. So the push is going to be from your clasp arm or your retentive arm. But if you have a buddy standing next to you, or a wall standing next to you, then that acts as a reciprocal arm or a bracing arm. So as you take that partial denture in and out, it won't torque the tooth as much when you have that reciprocal arm behind it. And we have several different types of super bulge clasps. So the ones that come above the survey line, they're all listed right here. We'll show a few of them. I'll say the very most common one is going to be an Acres clasp. Some people call this a C clasp because it's shaped like a C. But I'll say for tooth supported partials, an Acres clasp is usually where we're going to live. And then infrabulge are the ones that come from below the survey line and engage. These can be a little bit more aesthetic. And of these, the most common is going to be what's called the eye bar. So the Acres clasp and the eye bar are going to kind of be the two most go-to clasp arms. And we'll show pictures of those as we go through. All right, so we talked a little bit before about partials that move and partials that don't move. The reason why partials move is because that soft tissue is compressible. And when you compress that soft tissue and that partial moves, it moves across what's called a fulcrum line. So the partial will rotate around that fulcrum line towards the soft tissue. The fulcrum line goes through the distalmost rest seat on either side of the arch. So here we have our fulcrum line going across the two teeth on opposite sides of the arch, and that's going to be the line that partial will rotate around. And this is showing what that looks like. We don't have a tooth to provide support or a rest seat to provide support in the back. And so that partial will actually displace and rotate. So when your Kennedy class 1 and Kennedy class 2 patients say your partial is moving, this is that type of movement that they're experiencing. This can be counteracted by placing dental implants. So you could place a dental implant here in the posterior section with a locator attachment, for example, or even a crown. And now it's converted this from essentially a class 1 or class 2 to a class 3 partial that has support on both ends. However, to try to counteract that as best as we can, we'll do what's called an indirect retainer, which is basically an extra rest seat that is across from that fulcrum line. So if we go back here to this, where we see the fulcrum line going across the two rest seats, you'll see this other perpendicular line coming over to the canine. So that canine tooth, the arrow going this way points at the best tooth to provide that indirect retention. So to help counteract some of that fulcruming, we can put a cingulum rest here with a plate on that canine. And really the role of those is, I always say, to avoid sticky things, so it keeps it from lifting so much. And this is going to demonstrate that fulcrum line. This is from a colleague that's actually now, it says University of Iowa. He's now at AT Still in Arizona. And he has a fantastic YouTube site. So if you do a lot of partials, he is the king of partial dentures on YouTube. But basically what happens is you'll apply a force to the tissue-borne portion of the partial denture. Here we have our rest seats. So that's going to be our fulcrum line in red going through the two distal rest seats. And then we have our cast clasp arms right here. So if you have a distal rest, you're going to see that that tooth will actually be torqued towards the movement as it resists. And so you can actually start to cause mobility in that tooth as it rotates around the fulcrum. So in our distal extension partials, we teach something called a rest clasp shift where you actually move the rest to the mesial side of the tooth. So typically on a tooth-borne partial, you'll have a distal rest, and a tissue-borne partial will have a mesial rest. And that creates a stress breaker where instead of being a class 1 lever where it seesaws off of that poor tooth, we've now shifted it so it acts more like a wheelbarrow and doesn't provide the same sort of torquing forces. So that's called a stress breaker or a stress director as you shift that rest seat from the distal part of the tooth to the mesial part of the tooth. And so what we look at is trying something with a mesial rest, and there's 3 great options that we choose for distal extension partials to provide that stress breaking. The first is going to be an RPI clasp assembly, which is a mesial rest, a proximal plate, and an I-bar. An RPA is a mesial rest, proximal plate, and an Akers. And last but not least, a wrought wire, because it's so much more flexible, provides stress breaking on its own. So if your patient already has a distal rest and you want to engage that, then you can use a wrought wire to provide that stress breaking. This was a really cool rule that makes me excited when I learned it, to determine how many direct retainers or clasps you need on average for your partial denture designs. So for a Kennedy class 1, which is going to be that double distal extension, you need 2 direct clasp assemblies, which are 2 clasps, and 2 indirect clasp assemblies to help counteract both fulcrums. For a class 2, which is the single distal extension, you need 3 clasps. So you'll have 2 on the dentate side and 1 on the tissue-borne side. And then you'll have 1 indirect retainer because you have 1 fulcrum when you push on that distal extension side. For a Kennedy class 3, which is a tooth-borne partial, you need 4 clasp assemblies. And for a Kennedy class 4, which is that anterior, you also want 4 clasp assemblies. And one of my students pointed this out, and it really blew my mind, that these all add up to 4. So a Kennedy class 1, you'll need 2 direct, 2 indirect. So 2 plus 2 is 4. Kennedy class 2, you want 3 direct, 1 indirect. 3 plus 1 is 4. And Kennedy class 3 and 4, you want 4. So these are just a few rules that we use to kind of do our quick guide. We want as little contact with a tooth and tissue as possible. So lots of windows. Think of a lingual bar versus a lingual plate if you can. You want to make big spaces, the 5 millimeters between the minor connectors. You just want everything open and cleansable as much as possible for the patient. For distal extensions, you want to put a mesial rest on those abutment teeth. And if it's a tooth-borne, you want the rest seats just adjacent to the edentulous span. For a tooth-borne partial, usually we'll use cast clasps to give that nice snap and rigidity, unless the tooth is compromised. So whenever you feel like you need to give the tooth a little bit of relief, whether there's periodontal involvement, there's a crown that doesn't have great prognosis or something like that, you might want to switch to a wrought wire clasp to have that innate flexibility that they have in the alloy. And so last but not least, when we're looking at distal extension, usually RPA or RPI will provide that stress breaking with a mesial rest, and wrought wire will be our next choice. All right. So to support those direct clasp assemblies, we need to prepare the teeth and do something called tooth modifications. So when we have a tooth-borne partial, we're going to want to do the guide planes, where we make the 2 surfaces parallel to each other to help guide that partial into position. And this is just showing kind of what that would look like. If you want to remember where you need to adjust it, you can do a blue hatched mark. If you don't have a great surface for your reciprocal arm, you can also do a little preparation there as well. From the occlusal rest, this is what we'd look at on a molar or a premolar. And this is kind of what that rest seat will look like on the framework. And when you look at it, it should be kind of a rounded triangular shape. So you have the base of your triangle, and then it kind of narrows as it's coming through towards the axial surface of the tooth. We want to make sure that all the line angles are rounded, as you always do with most of our preparations, so that you don't have any sharp enamel corners for the patient's tongue when they take the partial out. And when you look at from the side, you'd want to see kind of a spoon-shaped rest. And what I mean by that is the deepest part of the rest seat should be here towards the center of the tooth. So you want it kind of sloping down, like it scooped it out. So the deepest part is here towards that pulpal axial wall, and it's kind of a little bit taller on the marginal ridge side. To look at the dimensions, the buccolingual dimension should be about 1/3 of the tooth or 1/2 of the width between the cusp tips. And mesial distally, it'll be between 1/3 to 1/2 of the width of the tooth. For the cingulum rests, we're going to have a V. You can do either a V-shaped or a chevron, which will usually be maxillary teeth where you have a little bit more enamel. Most commonly, we'll do a ledge-shaped, or as I learned it was called, the hot dog. And last but not least, you can do a dimple rest with a round burr. So here's showing the chevron from the side, and this will be a maxillary canine. Here's showing the ledge-shaped, and this can be done on pretty much any anterior tooth. And then the dimple rest will be done in the marginal ridge area where you have that really thick enamel. And these are nice for those patients that have very thin enamel or very limited interocclusal space. Once you've done all your tooth modifications, time to make your final impression to get your framework made. Usually we teach alginate in a stock tray as kind of our go-to, a metal stock tray. You can use PVS in a custom tray. I get scared because these are the only custom trays I've ever seen get locked into someone's mouth. So if you have very divergent or periodontally involved teeth with big black triangles, use this technique with caution if you do PVS in a custom tray. And last but not least, you can scan for your partial denture framework. So once you have your framework made, you'll write your work authorization. Either you or your lab will survey and design together. If you do delegate this step to your dental laboratory, I really advise you to kind of work in concert with them. So have them send you back some photos or a digital preview so that you can approve the survey and design before the framework's made. So once we have our framework back, we want to check to make sure it's really well adapted, especially in all the rest seats and major connectors, that we can seat it and the patient doesn't feel any impingement. Oftentimes, we'll do the framework try-in by itself without the teeth so we can get a better view of what it is that's causing any impingement or misseat. This is a procedure I like to show. This is called an altered cast or a corrected cast. I tend to scan for everything, whether it's fixed, removable, complete, partial implants. I love using my scanner. So when I scan, I am usually aware that my distal extension or the soft tissue is going to be underextended, which is perfect to make a framework, but not perfect for the acrylic. So once I get my framework back, I'll add these little custom trays, chair side with some light curing base material, and then just do a little baby border molding in that little tray. So if you want to watch a video about that, you can look it up. It's either called corrected cast or altered cast, and you do that at the same appointment as your framework try-in. You can also, if you didn't get a great interocclusal record, do that at this point by adding wax to your partial denture framework. And then once you get that, you can do a clinical try-in. If you want to try the teeth separate from the framework, you can. Clinical try-in is pretty much the same as any try-in you do for a complete denture. When you're doing your insertion, you have two different things you're looking for, right? We have to make sure that we have great adaptation of the acrylic resin, same as a complete denture, but also great adaptation to the teeth for the metal framework. So you have to use two different media to see what's binding here. So on the acrylic part, you'll use PIP with a brush, the same as you're doing a complete denture. But on the metal part, you'll use something like an occlude or a fit checker or an Iowa wax or some sort of disclosing wax to see what's binding on the teeth. I personally use occlude. It's super messy, and I feel bad for my assistants that have to clean up after me. But that's something that works better in my hands. It's a little bit more user-friendly than some of the other materials. Sometimes you'll find that when you try your partial denture in, either at insertion or at the wax tooth try-in, that you don't have the same mounting, either digitally or physically, as you do in the patient's mouth. So at that point, you would want to do either a clinical remount or a laboratory remount to get everything back in the right position and readjust the teeth. And like complete dentures, you will have to do post-insertion appointments for most of your patients. We try to get the first post-insertion appointment as close to 24 hours after delivery as possible, whether it's a complete or a tissue-borne partial denture, because those soft tissue irritations will show up as red spots that we can see at that 24-hour appointment, but they haven't ulcerated yet. So if you can catch those before they cause tissue ulceration, it makes it a lot easier on your patient for healing. And I promised you I would talk about non-metal RPDs. And I'm going to start first with a very basic acrylic partial denture. So this would be the CDT code, like the 5821, where you're doing an acrylic partial. And here we have an acrylic partial that the lab has embedded wrought wire clasps. So whenever your lab adds clasps, they are made of wrought wire, which is the same that you can have soldered onto your regular cast framework. Or you can do what is often called a flipper, or technically speaking, an interim acrylic removable partial denture without clasps. I don't know why that hasn't picked up, but you can have a non-metal acrylic resin partial, regular process, milled, printed, whatever you want, with or without wrought wire clasps. Again, now we can do a lot of things digitally. So you can have either a monolithic milled partial denture, the same as you can for your complete denture. And after it comes off of the mill, you can embed some wrought wires if you want, if you have a physical cast. So this is a really nice trick. If you want to have something that's more repeatable, you can do a monolithic milled acrylic partial. More commonly now, we're seeing a lot of flexible partial dentures. I would like to challenge you to look at this picture of this flexible partial dentures, Valplast is the most common one, and see what component is missing. So we talked very quickly to do our crash course in partial denture components. And here you'll see we have what would be considered a major connector, right? We have what would be considered a reciprocal arm. We certainly have retentive clasps. And we have guide plates. But what are we missing? We're missing rest seats. And if you remember, what do rest seats provide? They provide support. And support is what keeps the partial from sinking onto the tissue during function. So when you have a flexible partial, you're getting retention from the clasps, you're getting stability from the design and from the guide plates and from the reciprocal arms, but you are not getting support. So those partial dentures will move up and down on the tissue. So even if they're very well designed, even though this is a Kennedy Class 3 Mod 1 partial, it is designed to move. Any of the flexible Valplast partials will move. These are very popular with patients because of the aesthetics, and they're very popular with dentists because they're super easy to seat. These almost always go in with very little adjustment. But again, long term, the patient's going to have movement that can cause tissue trauma and even tissue loss and periodontium loss. These can be conventionally processed. They're usually either processed or milled. There have been several companies now that have FDA cleared flexible printed resins. And I think as cost goes down and popularity goes up, you can start printing these in your practice, which is going to be really cool. Dr. Dukem, who is doing a lecture for you guys in the next couple weeks, I have the blurb at the end. He loves acetal partials. These are kind of a white framework that can be milled. And then you can have the framework with a mesh that you can add the resin to replace the missing teeth. You'll notice from the design, both pictures, how massive these clasp arms are, as well as how thick those rest seats are. This material is not as strong as metal, so you can't have 1.5 millimeters for a rest seat. You're going to need a good 2 millimeters or more for the rest seats and the clasps. And so patients will often say that these feel bulky, but it's another metal-free option that has a little bit more rigidity. It does have rest seats, so it has support, stability, and retention, unlike some of the other acrylic partial options, including the most common, which was that first one I showed you with the resin partial. You can now design and print these temporary partials, which is really fantastic. If you do have a printer in-house and a staff member that can help you design and get these run and finished. Printers are getting faster and faster, so you can print a lot of these in under a half hour. So this can be really fantastic if you have a patient come in on emergency, it's a front tooth, you can scan and print this quickly in-house. If it's an anterior tooth without a lot of gingival loss, you can certainly just print it in a tooth shaded material. Or you can add a pink composite or a pink layered acrylic. This is a product that I've been playing with that's really fun, where you can actually light cure this similar to Triad, and it will add some aesthetics to your temporary partials and complete dentures. This is a quick table if you want to grab a screenshot. Otherwise, I'm super happy to share this presentation however I can best share it to you by email or through Jessica. that has some of the CDT codes that you would use. There's a separate CDT code now for flexible partials. This is your conventional acrylic resin partial that we showed in slide 1, and your metal base partial dentures are here. And it kind of goes through some of the best long-term predictability options. I have acetal partials at the very bottom because I've seen some people treatment plan these as metal base partials. I've seen some people code them as acrylic and some people code them as flexible. So that's kind of a gray area where you might choose to code your acetal-based partial denture. And so to kind of summarize, we have a lot of digital options. We can digitally survey and design. We can cast, we can mill, we can print. But technology doesn't replace our traditional dentistry. It's helping make things easier and hopefully finding a way for it to work in your practice. So all the foundational principles are still there. The alloys are the same. The principles are the same. Support, stability, and retention are always the same. But now we have different ways to do things. And last but not least, thank you very much.